Mahony here. I'm going to talk a little bit about pediatric OSA and its relationship to the actual jaw structure. So I'm doing new patient exams today, and this lovely young lady, Jean, has come in to see me with mum, and Jean is 6, right? Okay. Now the history of Jean's case, she's been diagnosed with sleep apnea when she was quite young. She's already seen an ear, nose and throat doctor who's removed the adenoids and tonsils. In her follow-up sleep study, it still shows residual sleep apnea. Okay, so I'm going to have a little look in your mouth with, is that okay? Good on you, thank you. All right, now, if we have a look here, can you bite together? You can see the very narrow palate. You can see the cross bite. Now, can I get you just to say the word 66?
66.
Okay, now you say it again, 66?
66.
Look where the tongue's going. It's what we call a tongue thrust. So obviously that tongue thrust is contributing to the problem. Now, you put your chin up for 1 second and open really big. Big, open really wide. Wide as you can. Good girl. You can see how narrow that palate is. It's like a classic V shape. If you can you look up for me and put your chin up in the air? Can you look up that way? Put your chin up, that's better. Open really, really big. So that's what we're dealing with. Now, when you've got a palate that narrow, it itself will affect nasal breathing. And the tongue position is the other thing. Now let's look at the tongue. I always want people to check under the tongue for what we call a tongue tie. Can you open really big for me? And try and lift your tongue up. Now you can see this young lady finds it very hard to lift her tongue to the ideal position because she's very tongue tied. And even though she's been having a number of lessons with a speech pathologist, that really hasn't been addressed. So what we look at here is if we widen the palate, that will definitely improve the nasal airway. If we then release the tongue tie and do exercises for the tongue to sit on the palate, that will take the tongue away from where the obstruction currently is, and that will definitely help the sleep pattern, right? So what we're seeing here is a high palate on what we call a class 2 malocclusion. A class 2 malocclusion, can you just bite together again? Means that the lower jaw is behind its ideal position, the upper jaw is narrow, and then can you swallow again for me? Just swallow, and that's where the tongue goes. You can see it clearly there. Now open and just poke your tongue out. Can you poke the tongue out? You see how the tongue can go forward and open really big again. So we want that tongue to be working up here, but it won't at the moment, A, because of the tongue tie, B, because of the narrow jaw. So our goal in the orthodontic community is to widen the palate, change the class 2 bite, and that brings the upper jaw forward. This is part 2 of the clinical exam, and this is where I talk to the parents about what I think we may or may not need to do. And I like sending articles. Now, anyone watching this, if they'd like a copy of the articles I mentioned, the link between otitis media and poor swallowing, the link between tongue tie or ankylosing and development of the palate. So this is one of the papers. It's written by a colleague of mine, Dr. Audrey Yoon. Audrey is in California. She's a pediatric dentist who then went on and became a specialist orthodontist, and has also done a lot of research in sleep medicine at Stanford University with Christian Guilleminault. And here she's co-authored with Christian Guilleminault on the topic of ankylosing as a risk factor for maxillary hypoplasia. In other words, underdeveloped upper jaw related to the tongue position. So what I show parents here is that when their child lifts the tongue up, that's what is ideal. And we can see in this young lady this situation. And then the role and effect that has is the tongue is not doing its job in developing the palate. So we end up with a narrow jaw, which ends up with dental crowding later in life, and we end up with a high palatal vault, which impacts on the airway. So that's a very good paper and good evidence to support the concept of developing the upper jaw, and secondly, seeing if you can get the tongue on the palate. And this video is also, I think, a good example of what we're trying to aim for. So In this video, we're showing what an arch form should look like, and you just saw the arch form that was narrow. This is what it should be if the tongue's there. Now, in this case, the tongue's not there because of the tongue tie, and possibly because of the open mouth posture, nasal obstruction. That we'll investigate further with radiographs, etc. But if the tongue's not there, then the muscles of the cheek or the buccinator cause the jaw to become narrow, and that's what you saw. Now, if the jaw is narrow, then the lower jaw has to bite back, and that's what causes the overbite. So we're trying to not just treat the symptom, which is the crowding, but the actual cause, which could be here, the poor tongue posture, the nasal obstruction, and definitely, I think Mum would agree with this, we don't want to have your daughter on CPAP for the rest of her life. You know, CPAP is an Australian invention developed here, University of Sydney, by Professor Colin Sullivan, and it helps many people around the world. But the side effect of CPAP therapy for young children is that it actually prevents normal forward growth of the maxilla. So you end up with further maxillary hypoplasia. So my goal when it comes to a young child is obviously to work with the respiratory physician during the acute phase of the apnea, but then slowly wean the patient off the CPAP. And the way we do that is by changing the jaw structurally, and of course reassessing the sleep and making sure that the sleep is improving, etc., etc. So I think the take-home message here is it's three major factors: ear, nose, and throat, which has already been addressed; speech, tongue position, which is sort of addressed, but what hasn't been addressed is the structure. So for all the respiratory physicians there, the ear, nose, and throat doctors there, read the research, the up-to-date research from people like Audrey Yoon and myself that show that the jaw size and the jaw position affects this problem. So if you have a jaw back here, of course, no matter what you do, the airway will be compromised. If you develop the jaw and bring it forward, it's better for the child's speech, it's better for their function. You can see the bite. Maybe less need for orthodontics later in life, and certainly less need for pulling teeth out. So this is the concept that we're trying to work together. It's a multidisciplinary approach, but it's for the benefit of the children, because when they sleep better, their behaviour improves, their cognitive performance at school improves, and there's all these multi-layered factors. So we can get a young lady as young as 6, and we can do something positive that will get her facial growth back to normal.